Hi, Rahul.
Hello, ma'am.
Can
Recording?
you hear me? Yeah.
Yes, ma'am.
Ma'am, good evening.
Yeah, hi, Nisha. So, good evening, Young Turk. We are starting the Young Turk program. This program is to empower all the Young Turk in the field of research, publication, clinical, and everything. So, for today's session, we have with us our expert. Palvinder, can you please display your CV?
Ma'am, good evening. Nisha here.
Yeah, hi, Nisha.
How are you, ma'am?
Yeah, fine. Palvinder, can you display the CV?
Rahul Parvinder has joined, right?
One
Yes.
second, ma'am.
You will have to unmute her and make her co-host.
She's unmuted, ma'am.
And make her co-host, please.
Yes, ma'am. Done.
Okay, am I audible, ma'am?
Yes, you are.
Okay.
So, Palvinder, can you please share
Yes.
the CVs?
Yes, ma'am.
So, welcome, Dr. Vineet. Have you joined?
Ma'am, Vineet sir will join in 5-10 minutes.
Okay. All of you can present your journal. So you knows the number of me, Dr. Neeru Takral and Dr. Nishra Bhatnagar. You can contact us if you are interested to present any journal.
Dr. Parvinder, you can share your CV. Ma'am, we can start, I think.
Yeah, so for today's session, we have expert with us, Dr. Vineet Malhotra. Dr. Vineet Malhotra is the founder and director, VNA Hospital, New Delhi. Secretary, Andrology Section, Urology Society of India. He's Andrology Board Specialty Member, National Board of Examination, India. Organizing Chairperson, Androcon 2023. Organizing Chairperson, Andrology Workshop, Gujarat. Organizing Committee, Pironion 2023, Mumbai. National Convener, Andrology Subspecialty Urology Society of India. Co-convener, Andrology Subspecialty IFS 2022. Co-team leader, Global Andrology Forum, Cleveland Clinic. Invited plenary speaker on sexual myths in men. Editorial Board of Guideline for Male Infertility. Editorial Board for Male Sexual Dysfunction 2020. So there are so many accord in his CV. Welcome, Dr. Vineet. And today we have presenter with us, Dr. Palvinder. Can you present your CV, Parvinder? Your CV? So Dr. Palvinder, she is IFS Fellowship, Clinical ART, attending consultant at Dr. Sodhi Healthcare Multispecialty Hospital and IVF Center, Mohali, Punjab. So welcome Dr. Vineet and Dr. Palvinder. So we are having very interesting journal club.
Dr. Parvinder, please start.
So very interesting topic, clinical factors impacting microdissection testicular sperm extraction success in hypogonadal men with known obstructive azoospermia. All of you who are still not member of IFS, please become the member. It's hardly 7-minute times to become the member.
Yes,
Yeah.
ma'am. So
Next
are my
slide.
slides visible
Slide.
now?
Yeah, next. Yeah, yeah. You can.
Yes,
Yeah.
ma'am.
Full
So
screen. Next slide. Yeah, this is your
Yes, ma'am.
next.
Okay.
Next.
So this is the
Yes,
slide
you
for
are,
IFS
yeah. So you
membership.
have various advantage of becoming a member. You have free access to IFS Genius Junction Quiz, patient empowerment program. We are having this program every second and fourth Friday from 8 to 9, where we are having general intelligence empowerment program, young empowerment program, counselor empowerment program, nurses empowerment program, and self empowerment program. And this journal club is on every second and fourth Friday from 8 to 9 p.m. And we are having mentoring session also. So after this journal club, we are having interesting mentoring program also on the X-ray clinical embryology. So yes, you can start this, Parvinder.
Okay, a very good evening to all, and I would like to thank IFS and our coordinators to give me this opportunity today to present this journal club. So about the presentation, I'll be talking about the topic. The topic for today's discussion is clinical factors impacting microdissection testicular sperm extraction success in hypogonadal men with non-obstructive azoospermia. So this is an original research article published recently in Fertility Sterility Journal in the October issue of 2024. Speaking about the journal, the journal is the official journal of American Society of Reproductive Medicine. Elsevier is the publisher. Kurt T. Barnhart is the editor-in-chief for this journal, and this journal has a huge impact factor of 6.6. The author for the study is Dr. Sandro E. Esteves. He is a reproductive urologist, founder and medical director of Androfert, which is Andrology and Human Reproduction Clinic affiliated to the University of Campinas, Sao Paulo, Brazil. He is a renowned male infertility specialist with several publications in scientific journals like Lancet, Human Reproduction, Fertility Sterility. So the background for this topic, the non-obstructive azoospermia affects 5 to 15% of men undergoing infertility evaluation and nearly 60% of azoospermia patients. It can arise from factors like genetic abnormalities, congenital diseases, gonadotoxic exposure, orchitis, testicular trauma, and many cases are idiopathic. Varying degrees of Leydig cell insufficiency can coexist with spermatogenic failure in patients of NOA, leading to a decrease in testicular T production, which can exacerbate the spermatogenesis impairment. And this will reflect as a biochemical hypogonadism, which is characterized by low T levels in circulation, which affects more than 50% of the patients with NOA. That is why the hypogonadal men were studied in this particular study. The dilemmas that we have in managing hypogonadal patients with NOA are mostly these patients are advised microtesy, which is microdissection testicular sperm extraction procedure to get the sperm retrieval. But are there any other methods that can, or any other pre-treatment that can improve the surgical sperm retrieval rates in these patients? And even with microtesy, hypogonadal men may face lower success rates than eugonadal patients. Research on factors affecting the sperm retrieval success in these men with NOA remains limited, and there is little data on the effectiveness of using gonadotropins for hormonal stimulation in these patients. So the objective of this study was to explore factors influencing microdissection testicular sperm extraction success in hypogonadal men with non-obstructive azoospermia. This was an observational cohort study in the very clinic, which is Androfert, which analyzed data from 616 consecutive hypogonadal patients with NOA who underwent microtesy at this clinic between January 2014 to September 2021. It followed the STROBE guidelines for reporting the study findings. The Ethics Committee of University of Campinas granted the ethical clearance for the study. The inclusion criteria for the study was clinical and histopathological confirmation of NOA, although it was done at the time of microtesy. Absence of Y chromosomal microdeletions in AZF-A and AZF-B regions, which indicated the severe forms of spermatogenic impairment. Biochemical hypogonadism, relating to total T values less than 350 nanograms per DL, and sperm retrieval using microTSE. The exclusion criteria involved hypogonadotropic hypogonadism, obstructive azoospermia, concomitant thyroid diseases, history of any testosterone replacement in the past, prior sperm retrieval procedures, and hormone pretreated using drugs other than the gonadotropins. So the diagnostic workup of the involved population had semen analysis with confirmatory analysis to corroborate the initial diagnosis of azoospermia, clinical hormonal genetic workup of the patients involving karyotype, Y chromosome microdeletion screening, Prader-Okidometer was used to estimate the testicular volume. Physical examination was done to identify the varicocele. Hormonal assessment involved the assessment of FSH, LH, testosterone, and estradiol with the cutoff ranges as shown on the screen. The data was gathered and extracted using clinical management software. Age, BMI, smoking status, and various other demographic factors were recorded before hormonal stimulation. And for hormone pre-treated patients, additional data included gonadotropin treatment characteristics, the regimen and duration, and pre-microTSE hormone levels. Delta indicators were derived for hormone pre-treated patients to represent the absolute change in hormone levels from their respective baselines. In this study, the delta indicators for testosterone were measured, and they were also associated with the success of SR. The patient groups were the patients with biochemical hypogonadism were divided into two groups on the basis of FSH levels. The normogonadotropic hypogonadism with FSH values less than 12 international units per liter, and hypergonadotropic hypogonadism with FSH more than 12 international units per liter. And these cutoffs were derived from various other studies which I have given in the reference below. Hormonal stimulation and monitoring. The pre-sperm retrieval hormonal stimulation was given to patients who opted for it. They were explained about the associated cost, the side effects of the hormonal stimulation, and also the limited evidence supporting this kind of treatment. And at the patient's discretion, these patients were given the hormonal stimulation before a sperm retrieval procedure. It was given for a minimum of 3 months. The patient self-administered recombinant human choriogonadotropic hormone subcutaneously at a dose of 80 micrograms twice weekly, with adjustments made to maintain T levels between 350 to 900 nanograms per DL. When FSH fell to below 1.5 international units per liter, which was observed in patients on treatment on recombinant HCG, those patients particularly received a recombinant FSH in the dose of 150 international units added 3 times a week. An aromatase inhibitor was added when the testosterone to estradiol ratio fell below 10 during HCG therapy. Monitoring included hormone measurements and semen analysis after completion of therapy, on the day of planned surgical sperm retrieval. Whenever a viable ejaculated sperm was detected in the semen analysis, sperm cryopreservation was performed, and these patients were excluded from the study. On the day of sperm retrieval, all patients underwent a confirmatory semen analysis. Then sperm retrieval was performed at least 3 months later for patients with previous varicocelectomy. And the testicular biopsies were taken during this procedure of sperm retrieval, and histopathological diagnosis was made to categorize the patients into different categories according to the impairment in spermatogenesis as normal spermatogenesis, hypospermatogenesis, spermatogenic maturation arrest, germ cell aplasia like Sertoli cell only syndrome, and tubular hyalinization. The gathered data was analyzed by generalized logistic regression analysis to explore the relationship between clinical factors and SR success in both entire and hormone pretreated cohorts. The optimal cutoff values of these successful SR outcome were determined using ROC receiver operative characteristic curves and Yoden-J statistics. Pearson's square test and Wilcoxon test were used to compare the categorical and continuous data, and p-values more less than 0.05 were considered statistically significant. Out of the 652, there were 652 consecutive hypogonadal patients with NOA, which were screened during this time period, and out of which 616 qualified by inclusion criteria of the study. The overall micro-TSE sperm retrieval rate was 56.6%. That is 349 out of this 616 patients had a positive sperm retrieval. This table represents the demographic data collected for the patient. And out of this various data out of the various characteristics that we see in this chart, these were the independent predictors of SR success with significant p-values: baseline FSH levels, presence of clinical varicocele, history of previous varicocelectomy, sperm retrieval hormonal stimulation, testicular histopathology results. Now, how these were important for predicting the success of SR sperm retrieval was the lower baseline FSH levels and history of previous varicocelectomy were associated with increased odds of successful sperm retrieval, while the presence of clinical varicocele decreased these odds. Patients exhibiting biopsies indicative of hypospermatogenesis or maturation arrest had significantly higher odds of successful SR than those with Sertoli cell only syndrome or germ cell aplasia. Hormone pre-treated patients achieved higher sperm retrieval success rates than hormone untreated counterparts. As shown in this table, normogonadotropic hormone pre-treated patients achieved higher sperm retrieval success than their hormone untreated counterparts, which was 67.9% versus 50.1%. In contrast, there was no significant difference in sperm retrieval rate on success between hormone pre-treated and untreated hypergonadotropic subjects, which was 58.1% versus 51.9%. The receiver operating curves were made for the hormonal levels, which indicated that the basal FSH level of 9.8 international units, it distinguished between the positive and the negative sperm retrieval rate with an area of curve of 0.64. Similarly, for testosterone levels, the initial testosterone levels of 418.5 nanograms per dl had a area of under curve of 0.78, which was which significantly distinguished between the negative and the positive sperm retrieval rate. The delta T, which was the increase in the testosterone after the initiation of HCG therapy, was the cutoff for that test level was 258. That means that the rise of around 258 nanograms per dl in the baseline testosterone levels was significantly associated with the positive sperm retrieval rate. And combining all these hormone parameters, we obtained an ROC with an area under curve of 0.79, which was highly sensitive for predicting the successful sperm retrieval rate. So what were the complications and adverse effects with this treatment, with the study? There were complications related to the surgical sperm retrieval procedure, where 1.9% patients, that is 12 patients out of 616 patients, had complications related to surgery. 3 patients had scrotal hematoma, and there were 9 cases of wound infection, out of which 1 required a unilateral orchidectomy. In the group of hormone pre-treated patients, there were 10.3% of adverse effects noted, where 30 patients after 291 had those adverse effects, including injection site reactions, gynecomastia, mastalgia, persistent headache, erectile dysfunction, elevation of liver enzymes. And most of these complications were managed conservatively, where anastrozole was started in the cases of gynecomastia and mastalgia patients, and it was discontinued where patient had erectile dysfunction or elevation of liver enzymes. So it was mostly related to this aromatase inhibitor therapy. Now, coming to the discussion of the various predictors, FSH level as a predictor of surgical sperm retrieval success. Here, previous studies have demonstrated that higher FSH levels are associated with reduced sperm retrieval rates in the general population of patients with NOA, and this study also agrees to it, but extends this relationship to hypogonadal males too. The optimal FSH threshold to differentiate between hypogonadal males with positive and negative microTSA outcomes were 9.8, as we already saw in the ROC curves, which was consistent with the previous reports. The histopathological findings, how these are can predict the successful sperm retrieval rate. The higher odds of successful sperm retrieval in patients with hyperspermatogenesis versus Sertoli cell only and maturation arrest versus Sertoli cell only align with the prior studies. Histopathology specimens were obtained during microtesy, and approximately half of the cases were for hormone treated patients. This study used.
ज्यादा कुछ हुआ तो इसको देख देना, मुझे लेनी आ जाएगी.
So shall I continue?
Yes, please.
Yeah. So this study basically used the histopathology findings to confirm the NOA diagnosis. However, such practice is not favored because it could potentially reduce the chances of sperm retrieval success. How association of clinical varicocele impacts the sperm retrieval rate? Clinical varicocele was associated with decreased sperm retrieval success, corroborating the previous research. There were systematic reviews and meta-analysis in the past that have indicated that improved sperm retrieval rates after varicocelectomy in patients with NOA. However, current guidelines advise caution when discussing the varicocele repair in this scenario because of lack of high-quality evidence. The impact of sperm retrieval hormonal stimulation. This was the most novel aspect of this study, where positive impact of sperm retrieval hormonal stimulation was found, and it represents and this study also represents the largest cohort of hypogonadal men with NOA undergoing stimulation with recombinant gonadotrophins before the sperm retrieval procedure. 80% of the hormone pretreated cohort achieved normal T levels. After adjusting for confounders, hormone pretreated patients had 2.5 times higher odds of successful SR than those who did not undergo hormonal stimulation. So this regime yielded a greater benefit for normogonadotrophic patients than for those who were hypergonadotrophic, maybe due to hyperproportion of patients with genetic defects or showing the Sertoli cell only on histopathology, as well as low testicular volume and baseline T levels. This finding also aligned with the 2022 meta-analysis on the topic, where higher sperm retrieval rates were reported in men undergoing hormonal stimulation before treatment, particularly those who were normogonadotrophic. As how testosterone levels are associated with the success of sperm retrieval. Our findings suggest that optimal T levels of more than 418.5.
Dr. Parvinder, you need to finish it fast. Question and answers are there, and the next
Yes.
session.
Yes, ma'am. So here we used SCG, that has been the drug of choice because it stimulates the DNA synthesis and it boosts the intratesticular T levels, which also reflects in the circulatory T levels. So the previous report also found that the individuals who achieved a delta T level of 250 after hormonal stimulation had higher sperm retrieval rates. And how advantage of HCG over SOMs and over selective estrogen receptor modulators and aromatase inhibitors, it has an advantage of this is because the FSH levels are decreased after HCG stimulation, and 20% of patients had marked FSH level suppression, which required exogenous FSH supplementation. The FSH dosage used in this study mirrors the approach used for hypo patient in idiopathic infertility, and this patients used a combination of HCG and FSH more often than SR negative one. So sperm retrieval positive patients had a use of HCG and FSH more often than the sperm retrieval negative ones. So coming to the strengths and limitations of the study, the strength of the study was that it is a large cohort focusing on the hypogonadal men with non-obstructive azoospermia. Histopathological confirmation of NOA was done. Superior sperm retrieval rate with microtessy, as this was the procedure used, and hormonal stimulation with recombinant gonadotrophins was done only, and it decreased any other treatment biases. Limitations of this study was it lacks quantitative data on sperm extraction and lack of follow-up data on IVF treatment outcomes, as it is a retrospective study. There were pre-sperm retrieval hormonal stimulation on patient preference was done. Hence, there is a risk of bias. It could be a risk of bias involved. Only good candidates were selected for hormonal stimulation, as we could see from our inclusion and exclusion criteria. The T levels measured by electrochemiluminescence immunoassay instead of liquid chromatography, which is more accurate, so it can impact the accuracy. No consensus definition of norm or hypergonadotrophics, as these cutoffs were derived from the findings of the previous studies. And there was no analysis for inhibin B, AMH, and 17-hydroxyprogesterone, which are mentioned in other studies as well. So coming to the conclusion of the study, we wanted to see the clinical factors that impacted this microdissection testicular sperm extraction success. And here we conclude that baseline FSH levels, presence of clinical varicocele, history of previous varicocelectomy, pre-sperm retrieval hormonal stimulation, testicular histopathology, all these were important clinical factors impacting the success of sperm retrieval in hypogonadal patients with NOA. Study underscores the potential advantages of interventions before sperm retrieval, notably hormonal stimulation and varicocele repair in hypogonadal males. However, the standardized treatment protocols and the assessing the reproductive outcomes is crucial, and it has a scope for further research in this topic. So I thank you, and here I end my presentation. With your permission, ma'am.
Thank you, Dr. Palvinder. So it was a nice presentation. Welcome, Dr. Vineet.
Thank you, ma'am.
Good evening, ma'am.
Yeah, welcome. So we have lots of queries. So first is by Dr. Rekha Rampa. Please elaborate on the hormonal pre-treatment. So Dr. Vineet, what is your comment as she told? So can you briefly tell your conclusion to Dr. Vineet, Dr. Parvinder, what you told?
Ma'am, the conclusion, as we wanted to see what are the clinical factors that can impact a successful testicular sperm extraction in hypogonadal men with non-obstructive azoospermia. So here we concluded that the baseline FSH levels impacted this, along with the presence of clinical varicocele, history of previous varicocelectomy, and previous sperm retrieval hormonal stimulation, testicular histopathology. All these factors had an impact on the success of sperm retrieval procedure.
So the current evidence states that only histopathology can make a difference in terms of any pre-treatment change for men with non-obstructive azoospermia with regards to hormonal therapy. That too, when we are looking at eugonadotropic levels, not if you're looking at hypergonadotropic levels. So current evidence, unfortunately, is only for hypospermatogenesis on, if there is evidence of hypospermatogenesis on testicular histopathology, that's the only evidence available. Having said that, we still tend to use this if we find total testosterone levels below 300 and with a target testosterone of 600. So we still tend to use that, but there's no evidence available.
So if it's less than 300, you would definitely like to use the hormonal pre-treatment?
Yeah, we will use hormonal pre-treatment to raise the testosterone, total testosterone levels to 600, target of 600.
And what doses we are using here?
So my preference is now to use recombinant HCG and recombinant FSH, and I would use a Ovitril once a week of 250 and that's recombinant HCG of 250 and rec FSH of 75 units thrice a week.
Rec FSH 75 thrice a week.
Thrice a week.
So any cutoff value for FSH when you combine both or when you give only HCG? Like if it's, she told if it's less than 1.5, then only we add the FSH. If it's more, then we give only HCG. So what is your take on this?
No, I will use both in all patients that I'm aiming to
So what
raise.
limit you take for hypogonadin to say which value of FSH or which value of testosterone?
FSH doesn't matter. I take the value of LH. So LH has to be below 10 for me to stimulate with both rec FSH and LH, HCG.
Okay, so you see only testosterone value to label these
I
patients.
see only total testosterone and LH values. The FSH does not matter. Though, if you look at literature, they want eugonadotropic, which means they want levels of FSH and LH to be below 8.
Yeah. Okay, and if the patients who have hypo plus the estrogen and testosterone ratio is disturbed, TE ratio is disturbed. So there you combine an estradiol also in those patients?
Definitely. And there's evidence that you can use an anastrozole and Klinefelters. So when you're looking at men with Klinefelters, an anastrozole is shown to have good outcomes. So that's something that you can consider.
So you combine both.
Yes.
HCG, FSH as well as an estrozole?
No, then we don't use a rec FSH there. We would prefer an HCG with an the anastrozole.
Okay. So next is Dr. Yukti. When to do testosterone level in semen analysis after giving HCG? After how long?
So there are two methods to do this. One is mid-cycle and one is pre the next dose. And both of these are accurate. You can follow both of these. So you can do a mid-cycle or a mid-injection dose, or you can do a pre-injection dose. Both are, you have to only follow consistently whichever way you are following.
So you have started the treatment. So you'll repeat the values after 3 months, I see.
So if we are giving a pre-treatment, yes, it will be 3 months. Otherwise, it will be at 1.5 months if we are doing a total testosterone at that level, at 6 weeks.
Okay. Next is by Amit Shah. In Klinefelter syndrome, pre-treatment required or directly TISA or micro-TISA?
No, it would depend on the total testosterone. In fact, I would tend to more often treat because there's good evidence for Klinefelters with pre-treatment. If you see Ranjit Ramaswamy's paper, there was a lot of recovery or retrieval, very high rates after pre-treatment. So, in fact, the better evidence is available for Klinefelters.
Okay. Next question is by Dr. Amit Shah. Dose of anastrozole.
So again, anastrozole also has sexual side effects, which is why my preference is not to use that more than 1 milligram alternate day. I tend to use it at 1 milligram alternate day to 1 milligram a week, depending on what the estradiol levels and TE ratio is at.
Okay. And you use letrozole also in some cases or anastrozole also?
Less commonly. And if we have men that have more sexual side effects such as loss of libido, we would prefer letrozole.
So what dose?
2.5 milligram, 2.5 milligram, again, alternate days up to once a week.
Up to once a week. Okay.
Yes.
Next is by Parvati Devi. Treatment protocol to add anastrozole in Klinefelter.
I think I've already mentioned. So if you're using HCG, you can add, based on the TE ratio, you can add anastrozole alternate day, 1 milligram.
Okay. Next question by Dr. Amit Shah. What to give for pre-treatment in Klinefelter? That has already been
Answer.
Loveleen Sodi. So anastrozole and HCG together in Klinefelter? Yes.
Yes. So if you're using clomiphene with HCG, remember HCG will lower the FSH and so it will have a negative impact on the gonadotropin levels. So if you want to sustain or maintain the FSH levels, you can add clomiphene or you can add anastrozole and you'll have some maintenance of the FSH levels.
So thank you, Dr. Vineet, for the wonderful input. Any other input or you would like to give to the audience? For
It's
the
very
successful
important
outcome.
It's very important to balance. See, remember when you are delaying a sperm retrieval procedure, this could lead to a lower outcome of sperm retrieval also. So it's very important to balance, judiciously counsel the patient that when you are giving pre-treatment, it does not have discrete evidence and you will balance it and the time of the pre-treatment with the fact that there may be, a gradual natural progressive decline of chance of sperm retrieval also. So there's got to be a very balanced approach to this and counseling is very, very necessary in patients. I think this is a message that should be taken.
Yeah, definitely. And last question by Dr. Gaurav Jain. Patient having normozoospermia but could not give sample on the day of OPU and we did TISA. Then why we could not get normal morphology sperm?
Why did you do teaser? I would not do teaser. I would give a vibrator and get normal morphology sperm.
Yeah, definitely.
So I mean, I would think that for not getting normal morphology, there would be some other pathology involved. But otherwise, I would rarely ever do a sperm retrieval procedure for anejaculation. Almost all of these men will ejaculate with simple vibrator use.
One question by Dr. Rekha Rampata. Duration of pre-treatment.
Maximal duration should be 3 months. There have been some studies where they've done it up to 6 months. where a previous microtesa was also done. So, in that case, you have to wait for 6 months, but otherwise, ideal and optimum is 3 months.
So how do you counsel, in how many percentage you get?
No, this is, you have to
In your
counsel
cases?
that there is very weak evidence and we are doing it because this microtesa is a last resort chance and we're trying to optimize everything. Otherwise, I don't give them any percentage at all. Evidence doesn't support it.
Okay. And management of retrograde ejaculation, I think.
Sperm retrieval with ICSI. I don't believe in retrieval of sperm because most of it ends up being used for ICSI only. We have very poor results with IUIs. So I'm a believer of testicular aspiration and ICSI.
Yeah. So thank you very much, Dr. Vineet. Thanks for the joining and giving the wonderful inputs to the audience.
Thank you so much, ma'am. And I hope to be present sometime again.
Yeah, definitely.
Thank you.
So, Palvinder, you would like to say anything?
Ma'am, thank you, ma'am. And we are honored to have such a esteemed expert for this session. I'm happy that sir could give his insights on the topic. And now I think the remaining doubts are cleared.
Yeah. So can you please show the CV of Dr. Fasina? Please share the CV of Dr. Fasina. So Dr. Fasina Sethi, she is a ASHRAE certified senior embryologist. Welcome, Dr. Fasina. She has a 19-year experience in the field of clinical embryology. She is MSc from Leeds University, UK, 2011 to 13. Cluster head, Bella Fertility, ARMC. Senior embryologist, Bella Fertility, Parenthalmana. Former embryologist at ARMC IVF Fertility Center. Former embryologist at Mulana Hospital, Parenthalmana. Member of SR IFS ACE Embryology Consensus Group. Contributed a chapter on INSAR Consensus Guideline on PGT on IVF Clinic, published in 2021. Contributed a chapter on commercially used catheter for embryo transfer in manual assisted reproductive technology and laboratory science, published by IFS. Areas of interest are embryo biopsy, cell culture, and QC/QA. So welcome, Dr. Fasina.
Thank you, ma'am, for the kind introduction. Hope I'm audible to you all.
Yeah, definitely.
Yes.
So you can share your slides.
All right.
So Dr. Fasina will going to tell you about the ASHRAE certified clinical embryology. Yes, Dr. Fasina.
Yes, I'm sharing 1 second. Visible, no, ma'am? My PPT is visible, no? So I have been asked, first of all, I shall thank the IFS organizers for giving me an opportunity to talk about the certification course. And I guess there are people here who want to appear for the exam sooner or later, and everyone must be knowing about this more or less. And I would like to share a few things which might be helpful for at least some of you. So, as you all know, first IVF baby was born in UK, Louis Brown, in 1978. And eminent scientists Edwards and Steptoe were the experts behind this miraculous or revolutionizing procedure. By 1982, roughly 300 IVF pregnancies had been reported and discussed by pioneers in the field all over the world. In early 1980s, IVFs were successfully established by clinical teams, collaborated with research scientists from basic biological or biomedical fields, and there were also veterinarians with practical experience in animal reproduction, as well as there were individuals from several other backgrounds in the initial periods. The scientific aspects were learned either on an apprenticeship basis or by self-education. Mid-1990s found a revolution in ARTs such that it was evident that success is more dependent on scientific knowledge and expertise. Over time, IVF has become a routine medical specialty. And the need for specific knowledge and skills for manipulating human gametes and embryos, performing high technology procedures, and consistently ensuring high quality culture conditions, all of these led to the establishment of a new discipline in lab medicine, our own clinical embryology. And is our specialty recognized properly? I think no formal recognition of this specialty existed earlier in most countries. So, to bring further clarification and harmonization, ESHRE decided to establish a European certification program with a comprehensive scientific curriculum. And accordingly, in 2006, it was decided to create an ESHRE task force for the certification of clinical embryologists aimed at providing wide and formal recognition of the status of the clinical embryologists. And this certification task force, they established contact with several professional and scientific bodies like alpha scientists to seek input in the curriculum topics, and this resulted in the establishment of ESHRE Embryology Certification Committee, who developed the two-level program, one basic level and the other the advanced level. And coming to history, it was the first exam was held at the ESHRE annual meeting in Barcelona in 2008, where only candidates of the senior level were allowed to participate. From 2009 onwards, the system was also open to the junior embryologists. And in the period 2008 to 2018, the certification program underwent several improvements by introducing electronic exam evaluation in 2011, external validation of the diploma in 2012, and online application platform was introduced in 2015. And it was open for non-European embryologists in 2012. In 2015, they introduced an online system for monitoring CPD, continuing professional development programs for all the certified embryologists. Coming to the timeline of 2025 exam, which is the next one, next year, it actually earlier the exams were held at all the annual meetings since 2008. And each exam comprised of 100 MCQs with 50 level specific questions and 50 questions common to both levels. The exam time is 2 hours and 15 minutes and score of 66% mark is required for the pass. 2025 embryology exam will be held online in mid-October. Actually, COVID was the time when they started doing complete online. There was 1 year where ESHRE was not, there wasn't an annual meeting. Next year, 2021, there was only the online. From that year onwards, online exam was the only option. So even next year also, there will be only the online option, not the physical one. And the application period will be from February 1st to March 31st, 2025. Coming to deadlines, a total of maximum 420 applicants will be accepted to sit for the exam. And if the maximum number is reached before the deadline, fully completed electronic applications will be added to the waiting list. Any declined or cancelled applications will be replaced by applications from the waiting list until beginning of May. By the end of the June, all applicants will be informed whether their applications are accepted or declined. And why this is relevant? Because it's one of the most internationally recognized certification program, and there is participation in the CPD programs is possible, and they will officially record the CPD system status on the list. And the once you are certified, this facilitate our opportunity to practice internationally. And how to apply for the exam? First criteria is that you need to be an active member. You need to take the membership, and the membership should be active during the whole application process until the publication of the result. And the first thing you have to do is to validate our highest qualification into NUFIC prior to application, which is a Dutch organization for international cooperation in higher education. Only NUFIC validated diplomas or degrees will be allowed for the exam. And this validation process will be coordinated by SRA and will be available from November 15, 2024. After submitting your validation, the candidate will receive a payment link to settle the fee of €50, which is non-refundable at any circumstance. Once the fee is paid, SRA will send your request for validation to NUFIC. Only after the validation process is completed and accepted, only then the application process will be initiated. For this process, we need to create my SRA account at the certification platform, log in with your username, fill out the application form for the corresponding exam level. So you need to select which level you are going to appear, and it cannot be changed. Upload the required documents in the PDF format. A payment link for the application fee of €150 will be received. Only fully completed and correctly submitted applications with successful payment will be reviewed by the certification steering committee. As soon as the application is accepted, this will be communicated via application platform. And what are the attachments we require during our application process? We need to provide the originals or validated copies of the relevant highest degrees and academic transcripts, which, as we all know, is the mark sheets. And you need to submit CV in English according to the Europass format. And any format other than the Europass format shall not be accepted. And the format is available from the website as well, which is not a difficult task. And we need to, so as soon as you plan for appearing for the exam, you need to fill your logbook. What is it? And first thing, you need to decide which level you're going to appear. And the first junior level is those who have the BSc degree in natural or life sciences, and those with 3 years hands-on experience with gametes and embryos in NAT lab, and with a minimum of 50 hands-on procedures per lab topic will be eligible for junior level or the basic level. And those with an MSc or PhD degree, or those with 6 years hands-on experience in lab and more than a minimum of 50 hands-on procedures per lab topic will be eligible for senior level. And what are the lab procedures you need to fill in the logbook? These are the oocyte retrieval, semen analysis, semen preparation, IVF insemination, XC zygote embryo evaluation, embryo transfer, cryopreservation of oocytes or embryos, thawing or warming of oocytes or the embryos. So you need to fill how many cases you have done in the logbook. And regarding the logbook, for the information from the application and the logbooks had to be verified and signed by the supervisors from the respective centers in which you are working. 2 references were required to support the application, preferably being SRA members and or SRA certified senior clinical embryologists, but this is not a must. If the candidate had been working at different centers, separate signed logbooks are required. From the glossary, you need who should give the reference, who should we put as a reference? The professional, any professional in the field of reproductive medicine who knows the applicant and whom SRA can contact in case there is a problem with the application to verify any declarations, and preferably an SRA member, especially an SRA certified clinical embryologist, can be kept as a reference in our application. He or she should be different from supervisor. This is very important because I know persons who had kept both reference and supervisor as a term, their application was rejected. And who should be the supervisor? The lab professional with the ability to guarantee the correctness of the logbook data, and who should preferably be an SRA member and an SRA certified embryologist should be kept as a supervisor. These two, this is very important that you have to keep it, and this you should be honest in all aspects. A first-time applicant must ensure its logbook is in the provided format in the website. Any other format will not be accepted. It's very important. An applicant who has been accepted for the exam before must update its most recent logbook according to the provided format. Previously accepted logbooks can be accepted provided they still meet the current requirements. So if you are once you are in the waiting list, again, if you are opting for the second term, you need to update your logbook. And prior to submitting the application, the applicant undertakes to receive a prior written and informed consent from the references and the supervisors regarding the use of their personal data. This is a logbook sample which we have to submit along with the application. This is just a timeline which shows throughout the year, the academic qualification validation process can be done through the online platform. Then in next 2025 February and March, the exam application will be available Mid-October, the online exams will be conducted, and by mid-November, results and the certificates will be issued. So we need to keep a watch on the website, and the dates will be announced soon. This is from the website itself, where it shows the academic qualification validation process is going to be the first step where we have to, once it is done, once your qualification is validated and accepted, only the application process will be can be initiated, and this will be taken by ASHRAE itself. And for this first half, you need to pay for the validation 50 euros, then the second process 150 euros. And once application is reviewed by the certification steering committee, you will get information about whether it's accepted by end of June, and by end soon after, if it is not okay, everything application will be declined, and that will be the end of it. And by I think in 2025, it's mid-October is the scheduled exam date. Online exam, it will be online exam by assessment queue. Mid-November, the results will be out. And just to give some information about the ASHRAE membership, anyway, you have to have the active membership during the application process. And it's open to all individuals who are active in the field of reproductive medicine, including doctors, scientists, students, and support personnel. What are the benefits? There will be reduced registration fee for all the annual conferences. For all the campus workshops, there'll be free access to eCampus online learning platform, and free access to the online on-demand courses 6 months after the event, full access to the online journals, access to a job board with info on latest vacancies, downloadable slide sets from campus courses, regular alerts on the latest research. So it's all in all advantageous to have an active ASHRAE membership. And there was an article which showed 10 years, what happened over the 10 years certification program. And on an average, 8% of applications were rejected, and most common reasons were the inadequate level of education on verification process and incomplete logbook, inadequate working experience, late submission, incomplete application. These were the common causes for the rejection of the applications. And the applicant can submit an application for the subsequent exam. If the submitted information turns out to be incorrect, the application will be considered null and void and will be considered as fraud and thus rejected. The applicant will no longer be allowed to take the exam to be valid. So once you are prepared to go for the exam, try to be as complete as possible and do it very carefully. And regarding the curriculum which is given in the website, there are 8 topics which include cell biology, genetics, developmental biology, female reproduction, male reproduction, MAR lab procedures, cryopreservation, lab and quality management. And the suggested reading list given in the website is, there are so many important books which is given in the website. You can rely on at least one of them and go through. It's it's not that an easy task and you have got 1 year. If you are planning for the next year exam, there is almost 1 year in front of you, and you can have a deep evaluation, deep knowledge, or studying on all the topics, and you can take the references of almost all these in the website. And I would recommend all of you to, if you are planning for the exam, you definitely, I had also did this course when I took my certification course in 2021. When I cleared my junior level, I had gone for this. I had attended it physically. It was simply awesome. And we had all the good faculties taking classes, mock exams were given. And it was really the guidelines or the guide given from this program that I could clear in my first attempt itself. So I think I had covered the important aspects, and I would wish you all the best if you are going ahead with the exam process. Good luck to you all who are opting for this. Thank you. Thank you so much for the opportunity.
Thank you, Dr. Basina. Thank you for enlightening talk and giving inputs everyone about how to do the clinical embryology Ashray certified. I think you have cleared everyone doubt, so there is no query.
Okay, ma'am.
So let's wind up the session.
Okay.
Yeah, thank you very much. Thank you.
Thank you, ma'am. Thank you.
Thank you. So you have done everything very clear toward how to apply and how to clear and how to go in.
Yeah. Are there anyone who are going for the exam soon? Anyone in the audience?
You can post your number. They can contact you or mail ID. Anything, anytime required, you can contact Dr. Basina. So nice
Okay.
of you to join. and
Happy to
share
share anything with you, if at all. Yeah.
Yeah, anyone in the group only you can add, I think, if you are here.
Okay.
Okay. Thank you.
Thank
Thank you.
you.
Thank you.